So good afternoon, everyone. Today we'll look at vasoactive drugs, and we're going to look at this lecture following outline. And so, by definitions, vasoactive drugs are those agents that affect the vasomotor tone, which is an important factor that determines the blood pressure. The vasoactive drugs affect the heart and the entire circulatory system. And they are mainly divided into three subgroups: the inotropes, vasoconstrictors, and vasodilators. All right, we just remind ourselves of some terms. What's an inotrope? Right, we know that it's a substance or an agent that alters the force of muscular contraction. So we can have either positive inotropes or negative inotropes. Vasopressors are agents that produce vasoconstriction and a consequent rise in patients' blood pressure. Vasodilators are agents that cause dilatation of the blood vessels with a subsequent reduction in total or systemic resistance. Chronotropes are those agents that alter the rate of a regularly reoccurring phenomenon, such as a heartbeat. So those agents that increase the heartbeat are known as positive chronotropes, and those that reduce the heartbeats are known as negative chronotropes. Inodilator are agents that have both positive inotropic effect and vasodilator effect. Lucitropes cause relaxation of cardiac muscles and chambers. And dromotrope are those that alter the conduction of electrical impulses through excitable tissues. And we can have either positive or negative dromotropes. All right, like I mentioned before, just in terms of classification of vasoactive agents, they can be classified basically into four groups: the catecholamines, the vasopressors, the phosphodiesterase inhibitors, and we have the calcium sensitizers. All right, each of these classifications of agents have specific roles and functions that they perform. All right, further classifications, vasoconstrictors can be divided into pure vasoconstrictors. What it means is that all they do is just cause increased peripheral or systemic vascular resistance. While the combined agents, those that have both vasoconstrictive and inotropic effects, are agents that cause both inotropic effect and vasoconstriction. And you have the noradrenaline in this group. In terms of vasodilators, we have pure vasodilators whose primary duty is to reduce systemic vascular resistance. And we have those who have both vasodilatory and inotropic properties, like the enoxaparin and all that. So how do these agents work? Vasoconstrictors stimulate peripheral alpha-adrenergic receptors. An example is the phenylephrine, which is a pure alpha agonist, stimulating the alpha-adrenergic receptors. We have those that stimulate adenine vasopressin V1 in receptors like the vasopressin. And we have those who have direct cardiac effect via receptors or ion channels and enzymes in the heart. Vasodilators can also be grouped on the basis of mechanism of action. Those that stimulate the peripheral beta adrenergic receptors, the isoproterenol. We have those who antagonize alpha receptors, the phenethylamines. These are used for adrenergic crisis. We have the calcium channel blockers, nicardipine, imodipine, And we have those who which stimulate dopaminergic receptors, and all the vasodilators are those who inhibit cyclic AMP breakdown, the enosamines. So talking about receptors, vasoactive agents, actually most of them worked by either stimulating or inhibiting some receptors or the other in the body. The adrenergic receptors are the alpha 1, alpha 2, beta 1, and beta 2 receptors. And activation or stimulation of alpha 1 receptors, obviously, we know cause vasoconstriction. In terms of location, the alpha 1 receptors are located in vascular smooth muscles and in the walls of the heart, while alpha 2 receptors are located in blood vessels. Stimulation of beta 1 receptors, right, they are located in the heart, increase heart rate and myocardial contractility. Beta 2 receptors are located in other parts of the body apart from the vascular system. They are located in the respiratory, the uterine and GIT, the gastrointestinal system. And they can cause, both vasodilatation and relaxation of bronchial, uterine, and GI smooth muscles. We have dopaminergic receptors, which we have from D1 to D5, and stimulation of D1 to D5 receptors lead to excitatory effects, which increase cyclic AMP formation and PIPI2 hydrolysis. The D2 to D4 dopaminergic receptors are inhibitory in nature and causing vasodilatation, thereby reducing systemic vascular resistance. The third one are the vasopressin receptors, the V1R to V3R, and the drugs that act on that, especially the vasopressin group. All right, this is just a slide to show us the different alpha receptors and beta receptors, where they are located, all right, what their stimulation or inhibition does in the body. And some of them I've mentioned them before. It's good to familiarize yourself with these receptors. All right, this active agent is a table. I hope you can see very well that shows the different agents and their primary sites of action. For instance, the epinephrine adrenaline, all right, acts on alpha 1 and beta 1 receptors, and with the ultimate goal of producing vasoconstriction. Norepinephrine is acts more on the alpha 1 receptors and causes profound vasoconstriction, and that is the reason why it is usually used in septic shock in critical care settings. Phenylphrin is a pure alpha 1 receptors, like we mentioned. Dopamine have both alpha and beta 1, and they also have dopaminergic receptors. All right, the glutamine is more of a beta 1 agonist and leads to increased contraction. And so prednisolone also is what's it called, a beta 1 specific, stimulants, and causes profound contraction. Also has effects on other receptors in the body. In terms of nomenclature, we have, basically speaking, vasopressors, under which we have adrenaline or epinephrine, norepinephrine, phenylphrin, ephedrine, and vasopressin. Strictly speaking, inotropes, pure inotropes, have agents like dopamine, dopamine, amiodarone, and mirinone. Okay, this is just also show you, I'm sure when you get the slide, please do familiarize yourself with some of this table that I've shown. I'm trying to, oh, sorry. Okay, you can see. Okay. All right, so what are the indications for inotropic support? Inotropes are indicated in low cardiac output states such as cardiogenic shock, which we discussed in our last lecture. All right, and in summary, we have I've listed some indications for inotropic support, both in anesthesia and critical care setting. Cardiogenic shock, septic shock, and heart failure, pulmonary hypertension. After open heart surgery, sometimes you need hydrogens to maintain the functions of the heart. After major surgery, major trauma, and sometimes allergic reactions, those also because of the significant patients in hypertension with a drop in blood pressure and also the effects of the allergies on the cardiac output. So these are some of the common indications for inotropic support. All right, vasopressin inotropic interior lacking hypotensive states in shock. All right, just selected this table to show you the common adult doses and selected characteristics. Noradrenaline, for instance, is given at a dose of 0.05 to 0.15 microgram per kg per minute, and is indicated in septic, cardiogenic, and hypovolemic shock. Adrenaline is usually at 0.01 to 0.2 microgram per kg per minute, and is indicated in cases of anaphylactic shock, and in instances where you need double vasopressin inotropic support, it can be added to noradrenaline. All right, phenylephrine is given at a dose of 0.5 to 2 microgram per kg per minute. All right, so for patients with septic shock in home, you do not want tachycardia. All right, the patients who develop tachycardia already, well, no epinephrine, no adrenaline, dopamine. You want to switch to phenylephrine. It is also indicated in persistent shock state, despite the use of 2 or more vasopressin inotropic agent, is used as a salvage therapy. And sometimes you have patients with high cardiac output, but with persistent hypotension. Phenylephrine comes to play. And dobutamine is given as 0.5 to 5 microgram per kg per minute, and is indicated in cardiogenic shock. It becomes useful as an add-on to noradrenaline in septic shock. All patients with ongoing hypoperfusion, despite adequate intravascular volume replacement and the use of vasopressin agent. So I've had cases where I've had to use triple inotropes, adrenaline, noradrenaline, dobutamine in patients in time past. So coming down to vasodilators, all right, we have examples, the sodium nitroprusside, the nitroglycerin, hydralazine, and others. All right, and they are classified on their side of actions. Those who cause arteriolar dilatations are known as arteriolar dilators, and examples are hydralazine and minoxidil. The vasodilators are those who cause vasodilatation, and examples nitroglycerin. Agents like nitroprusside, have both arteriolar and vasodilator properties. So we come to specific agents, we just dilate a little more on the specific common agents. The epinephrine adrenaline, it's beta agonist mainly, and its effect is dependent on the dose. At low doses, adrenaline epinephrine is a beta agonist, but the higher you go, it has just a more alpha agonist property. All right, what it does is stimulates the myocardial B1 and B2 receptors, which lead to increases in contractility and heart rate, with a resultant increase in cardiac output. Further, myocardial output is further augmented by an increase in venous return due to the alpha-1 mediated vasoconstriction, which increases venous return. We mentioned this before as 0.1 to 0.05 microgram per kg per minute, You have adrenergic mediated positive chronotropic and inotropic effects. For inotropic effects, this is I like this question because sometimes you're asked to differentiate the doses for inotropic support and the dose for resuscitation. All right, and this is important. Dose for inotropic support is diluted in 100,000, while dose for resuscitation is 1 in 10,000. All right, with high doses of adrenaline, you have stimulation of alpha receptors elsewhere in the body, for instance, in the precapillary resistant vessels of the skin, mucosa, and kidneys. And that's where you see some of these unwanted side effects of adrenaline because of the widespread alpha receptor stimulation in these organ systems. Noradrenaline is mainly an alpha agonist, but it has some beta agonist, which is not very significant. It has a dominant alpha agonist, I mentioned that before, and it is a preferred vasopressor in septic shock. It's assumed, it's been said that it tends to preserve renal blood flow. We're going to go into that as we go on. Note that noradrenaline should always be given the essential line due to its vasoconstrictive effect, which can cause ischemia, if it's given through the peripheral route. The most unwanted side effect is vasoconstriction and organ hypoperfusion in different organ systems, but it seems to preserve renal blood flow in this instance, and that is why it's a better choice in patients with acute kidney dysfunction. All right, with what's it called, what's it called, in septic shock. It's usually given at a rate of 0.1 to 0.5 microgram per kg per minute. And what we usually do is that we go 4 milligram and put it in 50 mils of 5% dextrose in water and usually titrated to a fed. It's better given to a syringe pump because it gives you a low volume effect of your dose. Phenylephrine is a selective alpha-1 adrenergic receptor agonist, and it causes dose-dependent arterial vasoconstriction with an increase in peripheral vascular resistance. And the good thing about phenylephrine is that as blood pressure increases, there's an activation of vagal reflexes, which tends to lower the heart rate. So it's commonly used in management of anesthesia-induced hypotension and patients in hyperdynamic septic shock. And I mentioned some of these things to you, the indications for phenylephrine use. It has a rapid onset of action, short duration, and primary vascular effect. So it makes it an ideal agent, especially in the intensive care unit. On a number of occasions, I've had to use phenylephrine in our ICU here, especially when noradrenaline is not available and we've got into the highest maximum dose for adrenaline. All right, we mentioned this before, it's an attractive agent for the management of hypertension in situations where you do not want the heart rate to increase. It's less likely to increase circulatory blood flow in the GIT when compared with adrenaline and non-adrenaline. So these are an added advantage in patients that you want to start enteral feeding for. All right, one of the drawback of adrenaline is the higher doses preclude enteral feeding because of intestinal mucosa ischemia, which could lead to a reduction in absorption and assimilation of your enteral feeding. But with phenylephrine, there is less likelihood of this happening, and we may safely administer enteral nutrition for patients on phenylephrine. The dose is about 40 to 180 microgram per minute. Ephedrine used to be the darling of anesthetists when I started my training. We didn't have noradrenaline or phenylephrine, so we resorted to ephedrine, but it has fallen into disuse with many anesthesiologists, except maybe in third world countries where some of these other newer agents are not readily available. All right, ephedrine is a naturally occurring sympathomimetic amine that is derived from plant. It has a direct non-selective activation of adrenergic receptors, as well as stimulation of adrenaline release from storage sites. It is less potent, longer than adrenaline, but tends to produce similar hemodynamic profile vis-a-vis cardiac stimulation and peripheral vascular, improves peripheral vascular resistance. Yeah, one of the reason why we use, especially for obstetrics, hypertension or hypertension following anesthesia for obstetric patient, is that it does not compromise the blood flow. So that even before the delivery of the fetus, a patient is hypertensive, ephedrine seems to be the agent that is commonly used because it ensures that uteroplacental circulation, blood flow, is continues unhindered. All right, it's given at a dose of 10 to 25 milligrams in boluses every 5 to 10 minutes. But because of tachyphylaxis, it's important that you do not exceed the dose above 150 milligrams in 24 hours. Other effect is myocardial ischemia and excessive vasoconstriction. And this is one of the major drawbacks why ephedrine has fallen into disfavor with many anesthetists and intensivists. All right, isopreterenol is a synthetic sympathomimetic amine, and with potent, non-selective beta-adrenergic activity. All right, its major cardiovascular effect is to increase cardiac output because of its direct positive inotropic and chronotropic effect. By so doing, it decreases heart rate and increases, atrioventricular nodal conduction. Know that there's reduction in systemic and pulmonary vascular resistance due to its beta-2 mediated vasodilatation in the skeletal and pulmonary vasculature, respectively. This reduction in pulmonary vascular resistance or peripheral vascular resistance leads to a fall in mean arterial pressure and diastolic arterial pressure. All right, although note that the systolic blood pressure is unchanged or may even rise owing to increased cardiac output. But remember, the coronary circulation is actually affected during the diastolic phase. Stimulation of beta-adrenergic receptors in the heart causes an excessive tachycardia, tachyarrhythmias, and may lead to myocardial ischemia. So this has limited its use to temporary treatment of hemodynamically significant bradycardia that is not responsive to atropine while you wait for a more definitive management or with the institution of external transvenous pacemaker. Vasopressin, the AVP, angina vasopressin, is an antidiuretic hormone, right? Primarily, but serves as a potential alternative to adrenergic vasopressors for the management of refractory vasodilatory shock. It was majorly by binding to vasopressin receptors, V1 receptors, or vascular osmosis. Know that it has minimal pressor activity in normal subjects. All right, vasopressin, however, has been shown to improve blood pressure in patients with sepsis and those patients with electric shock after being on cardiopulmonary bypass. It's also useful sometimes in ACLS, ALS, because it can be effective in treatment of cardiac arrest that is unresponsive to adrenaline and defibrillation. The revised guidelines of more than 13 years ago recommended vasopressin as an alternative to adrenaline for the treatment of adult shock refractory VF. All right. And it's also recommended as an adjuvant, all right, in the treatment of patients with vasodilatory shock, such as the septic shock or sepsis syndrome that are refractory to standard therapy. So it's not the first line agent, all right, but it can usually be handy, especially in cases of refractory vasodilatory shock. Yeah, dopamine is the darling of the anesthetists in the early 90s, because of its dose-dependent activity. All right, and because of that, I remember when we started training. All right, early days in my training. All right, dopamine was very common in ICU because we could vary, what the endpoint, on the basis of the doses. All right, so a low dose, especially doses less than 3 microgram per kg per minute, it seems to help with kidney and splenic circulation. All right, so in those cases where we have some degree of reduced cardiac output state with early onset AKI, we used to give low dose dopamine. It comes reflexly, However, between 3 to 10 microgram per kg, the moderate dose, dopamine acts on beta receptors in the heart and peripheral circulation, which tends to increase myocardial contractility with increase in cardiac output. We really used dopamine above 10 microgram per kg per minute, especially with the advent of newer drugs. But at this dose, the high dose, dopamine acts as a vasopressor, causing widespread systemic and pulmonary vasoconstriction. Like I mentioned before, at low doses, dopamine stimulates dopamine receptors in the renal and mesenteric, vessels, leading to vasodilatation and causes increased urine production, urine output at low doses. It's beta agonist effect comes with higher doses, and it causes vasoconstriction at doses of more than 10 microgram per kg per minute. Well, the only clinical use as of now, which is very rare because of the numerous side effects I'm going to mention very soon, is for cardiac stimulation and peripheral vasoconstriction at the intermediate dose of 3 to 10 microgram per kg per minute. All right, side effects include tachyarrhythmias. It causes digital gangrene, raised intraocular pressure. It can lead to delayed gastric emptying and all that. Because of these numerous side effects and the availability of newer safer agents, dopamine has actually been pulled out of most centers in developed climes. We used to give it at 200 milligram with 50 mg, 5% dextrose in water, and we titrate it according to effect. The bottoming, I remember that in 2005 was the first time I was an ample, 2005, where some persons brought ampoules of dopamine to our ICU then, and we were all excited to have the butamine, all right? The butamine is effective in both right-sided and left-sided heart failures because of its positive inotropic and chronotropic effect. It's a potent B1 agonist. We also have some weak beta-2 agonist activity. All right. Know that it used to come handy, especially for low cardiac output state, because it causes increased contractility and increased heart rate. Well, the beauty of it is that it also causes systemic vasodilatation. So as it increases myocardial work, it reduces the afterload. All right. So at the end of the day, you have increased cardiac output, all right, with reduced work to do to overcome the afterload. But it is contraindicated in hypertrophic cardiomyopathy because it's the myocardium is already hypertrophied, so there's limited increase in contractility that can be achieved in this heart condition. And know that it shouldn't be used alone in cardiogenic shock. Actually, it's not the first line of agent, but can be combined with adrenaline, in cardiogenic shock. The dose ranges between 3 to 5 microgram per kg per minute, and sometimes higher doses may be required. It's usually given at 215 milligram and 50 ml of 5% dextrose water. Know that it can actually cause malignant tachyarrhythmia, which, although lawfully is mild. But bear in mind that the butamine may be combined and usually combined with other inotropic and vasopressor agents in augmenting cardiac output and should never be used alone, especially in clinical situations of cardiogenic shock. All right, so this slide shows us the different mechanism of actions of different classes of inotropes, the dobutamine, digoxin, and mirinon, as you can see here. All right, the end of it is that there's an increase in intracellular calcium, all right, which, if you remember the contraction, coupling of your myocardial muscle cells, increase in intracellular calcium leads to increase in cardiac contractility. And that's how inotropes, leads to increased myocardial contractility. At the end of the day, it leads to an increase in intracellular calcium. Levosmidan is not new anymore. Those days it used to be new. It's a pyridosine denitrinylate derivative and has two important actions. Number one, it enhances cardiac contraction via calcium ion sensitization. All right, it sensitizes the cardiac muscles to increase the intracellular calcium that is made available. All right. It also causes vasodilatation at both arterial and coronary vasodilatation by opening the ATP sensitive potassium channel. If you remember, this is phase 3 of the cardiac cycle. All right, so levosmidan has found very useful place in the management of low cardiac output state because of these two mechanisms. And it shares the same property with dobutamine in the sense that it causes arterial and coronary vasodilatation, leading to reduction in afterload. But the mechanism of cardiac stimulation is different because for dobutamine, it's more of a beta 1 stimulation, while for levo, it's more of enhancing cardiac contractility by making the cardiac cells more sensitive to the intracellular calcium that is made available within the cells, the muscle cells. All right, levo is 98% bound to plasma protein and completely metabolized before excretion, which is good. All right, it's given at a dose of 6 to 12 micrograms per kg slowly over 10 minutes, or you can give it through continuous infusion at a dose of 0.5 to 0.2 microgram per kg per minute. Watch out for headache and hypertension that may result because of the widespread vasodilatation due to the opening of ATP sensitive potassium channel. All right, I decided to bring this out as a point of discussion. All right, especially those of you who have worked in ICU, and those of you who have been with me in ICU, we keep talking about these different, scenarios where we have to use vasopressors. For instance, for patients We all know that enteral feeding, early enteral feeding is good for our patients, but many of our patients are on one vasopressor or the other, and we need to juggle between considering when do we start enteral feeding, when the patient is on adrenaline or no adrenaline. All right, but we did say here that phenylephrine seems to preserve GI and mesenteric, microcirculation. But for patients who are adrenaline and no adrenaline, we need to be cautious. All right. This study by Carvalho and et al. All right. The title of their study, Vasopressors and Nutritional Therapy, safe dose for the onset of enteral nutrition. You can read it. It's published in Critical Care Research and Practice about just 3 years ago. So it's relatively a new article. Now, what they found was that the use of vasopressor per se does not impair enteral nutrition. That seems to be some good news. All right, but listen, they said they, however, have systemic effect that increase the risk of intolerance, among other complications, such as non-occlusive intestinal ischemia. All right, so despite the drug doses, in our ICU, say if I can get a dose of 0.01 microgram per kg per minute, I will start enteral feeding. But what he said is that despite the drug dose adjustment, clinical signs are still very most important in evaluating enteral feeding tolerance. What does that mean? If your patient, all right, residual gastric volume is less than 150 mil, all right, and then the patient requires higher doses of vasopressor, it's not a contraindication, all right, for enteral feeding. So clinical judgment is very important as you put this right aside, the risk and benefit of enteral feeding in the face of vasopressor use. Patients who are mechanically ventilated, does vasopressor, the use of vasopressor, have any impact on them? All right, this study by Warfare KS et al. On impact of vasoactive medication on ICU acquired weakness in mechanically ventilated patient, published about 5 years ago in Chest Journal. The reference is there. It says that mechanically ventilated patients treated with vasopressor medications had a more than 3-fold increase in the odds of developing muscle weakness. Oof. You see that? But a lot of times when we are doing multi-organ support with patients are vasopressor, patients are mechanical ventilation, but we have a 3-fold increase in this patient developing ICU-acquired muscle weaknesses. So each day that a patient receives a vasoactive medication, the odds of developing muscle weakness increased by 35%. Sudin, this is interesting for us to consider. All right, maybe we should look at patients who are on mechanical ventilator who do not require vasopressor treatment, and those who require, and see how many of them develop muscle weakness after 1 week. It may be something interesting to look at. What I think we need more studies, or we can do a systematic review of the existing literature before we can make a categorical statement. Well, obviously, patients on vasopressor who also require mechanical ventilation seem to develop muscle weakness by as high as 35%. That's like more than 1 in 3 patients. That's huge. Okay, what's it? Vasodilators. We're dealing with vasoactive agents, so we'll talk about vasodilators. Okay, we'll just talk about vasodilators, and we'll look at some studies before we round up. So nitroprusside acts directly on both arterial and venous vascular smooth muscles. So it acts on both, unlike the others who are either arteriolar of dilators. All right. The important thing about it is that nitroprusside has immediate action and short half-life. All right, it's indicated in cases of hypertension, we look at that state with increased systemic vascular resistance. All right, it's also indicated in post-cardiac surgery when you have hypertensive episode. But beware of silent toxicity with severe metabolic acidosis with the use of sodium nitroprusside. The dose usually between 0.5 to 5 micrograms per kg per minute that you try to effect. All right, nitroglycerin is a direct vasodilator with more effects on the venovascular smooth muscles. It reduces coronary arteries, therefore providing myocardial blood flow, improving myocardial blood flow and myocardial oxygen demand. All right, the indication most times is to improve myocardial perfusion following cardiac surgery, and is usually the drug of choice for management of post-operative hypertension. But you need to find out the cause of hypertension in the immediate post-op period. It could be pain, it could be any other thing, it could be sympathetic stimulation. But whatever it is, you need to find out the cause before you institute your choice, your vasodilators. All right. The side effect is the commonest side effect is metglobinemia, which you should be on the lookout for. Right. The dose is about 0.5 to 8 microgram per kg per minute. Hydrolysine, I'm sure we are familiar with hydrolysine. All right. It's a direct vasodilator which acts only on arterial smooth muscles. And it has nitric oxide enhancing effect. That's how it works. All right. The beauty of it is that it can be administered by oral or intravenously, and it is rapidly metabolized in the liver. All right. But know that it causes reflex stimulation of the sympathetic system. All right. Indications of the use of hydralazine as an intern, those days, there's no way you won't use hydralazine, especially for hypertensive disorders in pregnancy. So indications for hydralazine include moderate to severe hypertension, all right, especially in the OPD, somebody comes with severe hypertension, and with blood pressure hitting 250 over 150 millimeters of mercury, you want to just get hydralazine, all right? So in case of heart failure, pregnancy-induced hypertension, and preeclampsia, a lot of times for continuous BP control, you usually combine them with beta blockers and diuretics. And the side effects are numerous, and that is why you need to be careful when you are instituting hydralazine, because it can cause headache, severe hypertension, can result with ischemic episode, dizziness, it causes retention of fluid and salt, angina, lupus syndrome, angina, all right, ischemic heart disease from reflex stimulation of the sympathetic system, nausea, erythematosus. So side effects, I put them under hydralazine as my mnemonics. All right, so the dose for those who require chronic use of hydralazine, 40 to 200 milligrams per day. Yeah, minoxidil, the men amongst us may find it useful for alopecia, isn't it? But apart from alopecia, it's important, it's an important arterial vasodilator, but has no effect on the venous system. All right, it's usually metabolized to the active minoxidil NO sulfate by the sulfotransferase enzyme. All right, it's renal artery dilator and tend to improve renal function in patients with hypertension. The topical preparation is used for treatment of Bay pattern baldness and alopecia areata. All right, side effects can lead to increased hair production. It can cause fluid and salt retention. It can cause your T waves to become flattened and inverted, and you can have rashes from the use of minoxidil. And more severe is your Steven Johnson syndrome that may result from the use of minoxidil. All right, this table is adapted from DGVDITS, all right, in Hypertension Second Edition, published by S. Xavier Sanders in 2005. All right, it gives us a table of preferred parenteral drugs for selective hypertensive emergencies. All right, for hypertensive encephalopathy, the parenteral drug of choice include nitroprusside, nicardipine, and abetolol. For patients with malignant hypertension, where parenteral medication is indicated, labetolol becomes the drug of choice, followed by nicardipine, nitroprusside, and all. For patients with stroke, all right, nicardipine, labetolol, and nitroprusside in that order. For patients with unstable angina or myocardial infarction or ischemia, all right, nitroglycerin, nicardipine, labetolol, esmolol in that order. For patients with aortic dissection, all right, especially during open heart surgery, where you want to clamp and unclamp, nitroprusside should be one of the drugs that should be in your emergency tray. And an energy crisis, like your, what's it called now, this multi-endocrine disorders, patients with multi-endocrine disorders, patients that are coming for this common surgical procedures that tend to induce severe adrenergy crisis. Phentolamine and nitroprusside becomes your agent, a friendly agent. For patients with post-operative hypertension, like I mentioned before, we need to find out what is causing it. Sublingual nitroglycerin, the patient is awake. Nitroprusside, labetolol, and nicardipine comes handy. For patients with pregnancy-induced hypertension or preeclampsia, eclampsia in itself, the agent of choice for the management of the hypertensive emergencies are hydralazine, labetolol, and nicardipine. All right, there have been a number of studies that looked at the use of vasopressors in sepsis. All right, this was published in Surgical Infection journal in 2018. All right, and they found out that norepinephrine was the first line vasopressor in shock, and it was associated with low mortality as well as fewer side effects. They found out that dopamine had similar actions, but it was associated with significantly more tachyarrhythmias than norepinephrine. Epinephrine and vasopressin were found to be appropriate second-line vasopressors, and they also enabled use of lower doses of norepinephrine while improving hemodynamics. All right, so this is a good study paper for you to look at because it gives us a very wonderful background on the use of vasopressors in septics. All right. So in conclusion to that, it was appropriate treatment of sepsis includes prompt identification, early antimicrobial drug therapy, appropriate fluid resuscitation, identification of vasopressors in the presence of continuous septic shock. We don't wait until septic shock has gone out of hand before you institute vasopressor. Once you have determined that your patient has been adequately fluid resuscitated using your central venous pressure and your urine output, and the patient is still persistently in hypotensive shock state, you want to start vasopressor. Further research needs to be done to better understand the ideal timing. All right, when do we add the second agent? All right, after you started your noradrenaline as your first line, when is the perfect timing? How long do we wait before we add on a second agent like adrenaline or vasopressin? And a lot of times we have gone to strength adrenaline and no adrenaline in our ICUs before. But do we need to go that high if we can have a second line agent employed earlier on in the management of septic shock? All right, there's this study that compared ephedrine and phenylephrine as agent of choice for hypertension in elective cesarean section. All right, this was actually authored by Gonda C.P. et al. And in this study, they selected 100 ASA1 or 2 females who were scheduled for elective cesarean section under spinal anesthesia. All right, each patient was randomly assigned to 2 double-blind study groups. Double-blind study groups. Again, comes to play. I hope we have read around it. All right, Group E received ephedrine, while Group P received epinephrine in equipotent doses. All right, and heart rate, systolic blood pressure, diastolic blood pressure, and metabolic pressure were parameters that were compared, all right, within and between the groups to baseline level at the time of increment of 0 to 60 minutes from the start of surgery. Incidents of side effects and illness outcomes were also studied between the 2 groups. What did they find? They found that all the patients require some form of vasotherapy, vasopressor therapy for hypertension. So that means that it didn't just respond to fluid treatment. And they found out that administration of phenylephrine was associated with significant drop in heart rate, changes in systolic blood pressure, diastolic blood pressure, and metabolic pressure was found to be similar in both groups for most observed times. However, the incidence of nausea and vomiting and tachycardia were significantly higher in the ephedrine group. So they concluded that phenylephrine and ephedrine were acceptable choices to combat maternal hypertension related to spinal anesthesia in elective cesarean section. When they looked at the complications, they found out that complications of intraoperative nausea and vomiting, tachycardia and bradycardia should be considered when using vasopressor, which suggests that phenylephrine is still superior to ephedrine for combating hypertension following cesarean section in obstetric population. All right, this study was about 8 years ago. Is it 8 or more? That's about 5 to 6 years ago, which was published in New England Journal of Medicine by Ashikan and colleagues, where they looked at the use of angiotensin 2 for the treatment of vasodilatory shock. All right, they randomized patients with vasodilatory shock into 2, one receiving norepinephrine as 0.2 microgram per kg, and the other refused angiotensin 2 at equipotent doses. And the primary endpoint of their study was a response with respect to mean arterial pressure at 3 hours after the start of either what's it called, norepinephrine and angiotensin infusion. All right, they found out that at 48 hours, the mean improvement in the cardiovascular sequential organ failure assessment score, all right, ranging from 0 to 4, with higher scores indicating more dysfunction, was greater in angiotensin 2 group than the placebo group. All right. Now they concluded that angiotensin 2 effectively increased blood pressure in patients with vasodilatory shock that did not respond to high doses of conventional vasopressors. All right, this is just to show you the FDA approval of angiotensin 2 for septic shock. And they found out that 3 hours after administration of this angiotensin 2, almost 70% of patients reached target blood pressure compared to only 23% who received placebo or usual vasopressor like your noradrenaline. They clearly stated here that the study was not designed to detect mortality benefit. All right, they just looked at achievements of target blood pressure. And they also found out that patients receiving angiotensin 2 require lower doses of other vasopressors. Okay. But unfortunately, they found out that angiotensin 2 patients experience more incidences of thrombosis. All right. And FDA advised that angiotensin 2, the diapresa, can cause dangerous blood clots with serious consequences. And so prophylactic treatment for blood clots should be instituted when you have to use angiotensin 2 for refractory septic shock. Yes, these are my references, and we have likely exam questions for you. So, ladies and gentlemen, any questions? Any